question. Do you want me, this says the full bios are in the handout. Do you want me saying anything about them individually, or do you just want me to? Glow Infertility Summit presented by Truist. I'm Allison Lottis. I work at Channel 9. My husband and I were patients at REACH, and we know the journey of infertility, and I'm really proud to be a part of this nonprofit and proud to be a part of this event to answer questions, bring awareness to the struggle that so many couples face, and to give you hope and educate you on all of your options. I'd also like to welcome all of our friends who are joining us virtually. We have people from so many different states: North Carolina, Texas, Iowa, Alabama, Florida, Pennsylvania, Virginia, and we're really excited that they can be with us as well this evening. I'm going to help sort of facilitate the questions. Before we begin, I'd like to ask everybody to please silence your phones if you haven't already. And first and foremost, I need to hand it off to the host, co-founder, executive director of the Bundle of Joy Fund. We would not be here if it was not for Samantha Bush.
Thank you. Thank you, everybody, for coming. I am Samantha. My husband, Kyle, and I started the Bundle of Joy Fund in 2015. We struggled to have our son, Brexton, and ultimately went through IVF at REACH, and we had Brexton. Since then, we've been on quite the journey. We've experienced a miscarriage, a failed cycle, a failed surrogate cycle, so you name it. Tonight is about learning. Tonight is about coming and not being shy, asking questions. There's so many wonderful people up here on this panel. I understand so much how overwhelming this whole process can be. We've been in the midst of this for almost a decade, and I still feel like I'm learning new things constantly. So please come prepared with questions. Don't be shy. This is a safe space. I definitely want to thank all of our panel members for being up here tonight, and also just a huge thank you to Truist for being our presenting sponsor and all of our community sponsors here. So please, as I mentioned, don't be shy. I'm literally an open book. We all are up here, and we just want this night to be empowering and educational for all of you.
So I'd like to thank our community partners and vendors before we get started. Hyatt Place Downtown Charlotte, Fahrenheit, REACH, EMD Serrano, Theralogics, Elevation Outreach, Karen Rich Fertility Coaching, Barbara Metzler's, Certified Nurse Midwife, and Belly Baby. And if you didn't stop by all of their tables out there in the lobby, please make sure you do so before you leave tonight. So as Samantha mentioned, we have a lot of experts. We have people who have lived this journey to answer all of your questions. And we've got some prepared, and then we're going to sort of open it up to all of you. But what we'd like to do is, if you think of a question while we're in the process here, just raise your hand and we'll come around, get your question, and then we'll answer those later on, okay? So first I'd like to start with Samantha. So this is an emotional journey, and this is healthcare that is very delicate because there's so many emotions involved. So if you feel as a patient that your concerns are not being heard by your doctor, what should you do?
That's a great question. So I know that this topic for many people, let's be honest, it's a little bit awkward to talk about. It involves your sex life a lot and things going on, and people kind of shy away. But it's really important to come prepared when you meet with your doctor the first time. So have a list of questions ready, just be as prepared as you can. What I really like to do is go through, and I know this is going to sound crazy, but the hashtags on social media and read about other people's stories and learn from them and see different questions that you might pick up from listening to their stories. And then when you meet with your doctor, I feel like you guys have a really good conversation in order to start and learn and ask your questions. And at any time, if you feel like you don't understand something, or if you're overwhelmed, it's perfectly fine to say, wait, can we hit the pause button? Can you re-explain that? I'm just not sure. And that'll happen often. And then also, and as I'm sure all the REACH nurses love, they are there for you. So if you even think it's a silly question, trust me, they've probably had 9 million other patients call with that same silly question. But if it gives you a peace of mind, it's so important to make that phone call. So don't be embarrassed, don't be shy. This is your body and your healthcare, and so you have to speak up about it.
Thank you. Next, Dr. Seth Katz. He is the Chief Medical and Operating Officer for REACH Fertility Clinic. And my first question for you, Dr. Katz, is can you explain the process that patients go through to receive IVF from start to finish?
Yes. I asked for how long I had to answer these questions because I could speak for a while. But the, we'll start with a patient who already knows that they're at this point in the fertility journey, which is not the majority of patients that we see, but those patients who are already at the IVF decision tree. And once that decision is made to proceed, the initial step is to meet and make a protocol for that patient. And you know, there's different ways to get to the end result, which is to retrieve eggs and create embryos. And everybody's a little different and requires a little bit of different secret sauce to try to get there. And so we try to individualize the protocol for the specific patient and their specific issues. But you know, there's not that many different ways to do it, maybe 5 or 6 different protocols to stimulate the ovaries. So the basic initial step, think of the IVF process as 3 phases. So phase 1 involves kind of prepping the body for the IVF process. And that might involve the use of birth control pills, or it might involve some other supplements to enhance the response of the ovaries to the fertility drugs. And that process might last anywhere from 2 to 4 weeks. The second phase is the process of getting the eggs. And this is where all the shots come in. So the patients will take anywhere from 2 to 4 small injections a day, and for about 10 days. And during those 10 days, they'll be monitored to see the growth of the follicles where the eggs are, and then undergo a small procedure to retrieve those eggs. And so that's phase 2. Phase 3 involves the transfer of an embryo that's created from those eggs and the sperm from that retrieval process. And that process can take anywhere from 5 days for a fresh transfer, or up to 6 weeks for a frozen transfer. And so that's the basic process of IVF in a nutshell.
Next, we have embryologist Dr. Teal Taylor at REACH as well. After embryos are created, how is it decided which ones to implant or which ones to freeze?
So REACH is a little unique in if you look at a large portion of this country and a lot of the large centers, what they'll do is they will only freeze or use only your best embryos. And by doing that, they guarantee high success rates. What we learned at REACH is when we started transferring these less than suboptimal, although they are not as good embryos, they can still make a baby. So what we do now is we rank embryos either A, B, C, or D. Ds don't make it. A's are your best, and B's and C's are in between. And we'll utilize the A, B, and C embryos. And we have data to support, you know, hey, this embryo is a C quality. Instead of 60%, it may be 20%. At another center, they would have discarded that embryo because they want the higher pregnancy rate. But to us, it's not worth it. You know, 20% is still a good quality shot in our book. That's 1 in 5. So typically, embryos are ranked much like school, A, B, C, D. There's no F. But D's don't ever make it. C's 20%, B's and A's are pretty much the same. So there's, you know, you want A's and B's, but C's can certainly still make a baby, and that's the goal.
Robbie Bell is with us. He's a Bundle of Joy grant recipient. First question for you, Robbie, is what is a tip or lesson you can give couples after going through this experience yourself?
Sure. I think Sam hit the nail on the head, is to ask questions. Going into this, I didn't know anything, and it's really awkward for males to ask about women's health issues and things like that, but I ask a lot of questions to Taylor, to Dr. Katz when we were going through the process, and sometimes ask questions multiple times, again, like Samantha said. So I fully understood what was going on in the process, in the journey that we were going through. I think another thing that's really important is for the couples to be on the same page with each other. You need to understand what each other wants throughout this process, what your plan is as far as, hey, if we have one child, are we going to be okay with that? If we don't have any, or if we get so many embryos, how far are we willing to go into this journey with each other? What's our budget like? You know, that's going to be a big part of it, is how much money are we willing to invest going through this process. But you really have to be on the same page with one another going throughout the entire process to be successful, in my opinion.
Taylor Holt is a physician's assistant at REACH. We heard Dr. Katz and Samantha both mention the shots. So do you have 3 tips for giving a shot?
Yes. So yeah, the shots is one of the scariest parts of going through the fertility journey. Lots of my patients are very nervous about it. We have a lot of great resources. So at REACH we offer weekly nursing consults, and they'll go through injection teaching with you. The pharmacies are also really great about uploading videos, so you can watch YouTube videos to help you with those. But just like some tips and tricks, you can put ice on the area 15 minutes before the shot. Also with the progesterone and oil shot, that one is intramuscular, so it's going to go in the backside of the muscle. And that one can be very intimidating, but you can warm the oil up. So if you just put like a heating pad over it, or just warm it in your hands, it typically makes the shot go down a little bit better. And also just massaging the area. So there's lots of different things that you can do, and there's so many resources out there. Ask your friends, and having a friend help give the injections also helps, so you don't have to do it yourself.
Thank you. Tyler Bowery is the VP of Truist Wealth Sports and Entertainment Specialty Group. When it comes to affording IVF, that can be a huge obstacle for couples. A lot of insurance companies don't cover it. So what resources do couples have to afford the high cost of IVF or infertility treatments in general?
Yeah, so my wife and I have been going through the fertility process for a year now, so we're very aware of the cost that arises in this process. And so SunTrust has a division called Lightstream. It's in your packet, the link. You can go on and it gives you kind of dollar amount. It goes up to $100,000, but they kind of go in increments, and then they'll also do number of years. So they'll go all the way out to 7 years. But the tool is very useful in seeing, okay, to that point I would say get a budget tool like he mentioned. You've got mint.com is a free budget tool, and first get your budget and then figure out what the shortfall is, because you obviously don't want to get more money because it's going to cost you more in interest in the long run. So find out what that shortfall is, and when you go to this link, it lets you play around and kind of see what's the monthly payment going to be. So for instance, a $10,000 loan over 36 months is going to cost you between $300 and $350 a month in repayment terms. So you can kind of use that as a standard, more or less with that dollar amount. And then the application's very easy. It's probably 3 pages. The representatives get back to you within 24 hours. They might have a question, ask you to send a tax return. Sometimes if client's credit score is high enough, they won't ask for anything. They just say, send me your bank account number, and they deposit the money straight into your bank account. So you can have the money within 3 business days if everything, it goes according to their requirements.
Thank you. Elevation Church Partnership Coordinator and leader of the Womb Group, Kalisha Miller, is with us. This is a delicate conversation to have even as a couple, let alone to talk to strangers about this journey. A lot of people are so private about it. How do peer-to-peer support groups help couples mentally through this?
Yeah, I think they're very important because I think it helps with sometimes the stigma or the shame that sometimes women feel, or even couples feel, that this is something that we didn't expect to go through or be at, a place we didn't expect to be at. But I think the support groups really help because it gives you hope. So when you find these groups, whether it's on social media, whether it's in person, whether you find a friend group, you're able to talk to people that are going through the same thing. A lot of times you're able to see success stories. So when you're going through something, sometimes it's hard to kind of find that faith to kind of push through and keep the hope and belief alive that it can happen for you. And so I've found that when you're able to see other people be successful in something that's a barrier for you, it's exciting. It gives you the ability to just want to keep going and keep looking, keep researching, keep trying. also it gives you best practices. So a lot of times when you go to the doctor's offices, you only have so many minutes. Sometimes you forget questions to ask, but in those groups, you get best practices, the medicine to take, the best way to give yourself the shot. And then you get just a whole nother group of sisterhood and brotherhood and support that you wouldn't have had before. So I think it's important to be able to find those outlets where you can share. Another thing I found was that you're able to share in those circles when you're not ready to tell your family yet and you want to tell somebody, you're excited about the process that you're going through, but they're not ready, your family's not ready, you're not ready to share. And so in those groups sometimes you can share and get the support that you need until you're ready to share with your overall family and friend group.
You know, the reality is that's hard to cope with sometimes is that it's not a guaranteed success when you go through an IVF cycle. And Samantha, you've been pretty open about everything that you and Kyle have experienced. So how do you deal with loss and grief?
Yeah, it's definitely difficult. I think people turn to social media and they might see us out and about and smiling, but that's just a quick glimpse. It's definitely really hard. You definitely have your good days and your bad days, but there's a lot that you can do for support. You know, off of what you just said, the peer-to-peer support is so important, whether that's in person or now with all the different Zooms and apps and different meetups. I know it sounds very odd, but some of the deepest, closest conversations I've had are through DMs on Instagram with other women who know this exact journey. There's no small chit chat, there's no awkwardness. They get you completely from it's weird, you can be hopeful and feel hopeless at the exact same time. It's such an emotional roller coaster, and these women just get you. And so there's, you know, like I had mentioned, there's 1 in 4 app, there's Peanut, Resolve has different groups all around the country, and it's just so important to have, it's almost like a sisterhood behind you, cheering you on every step of the way. And it's really important because your friends and your family, sometimes they'll be able to be there to support you, and at other times they haven't lived through this, so it's hard for them to understand what you're going through. And as much as you want them there, also, like, after I experienced a miscarriage, I didn't want anybody to touch me. I didn't want to be around anybody. I didn't want to see that sad look in their eyes of, like, pity. And so it was nice to be able to turn to women on social media who knew just at the core what I was feeling, and they gave me ideas to help, you know, with grieving and coping and loss, and it really helped me through some of the hardest times. So find your tribe, like, it's for real. And I know it might be hard at first to reach out to a stranger on Instagram, but when you search these hashtags and you find these women in these communities, like, they're so ready to be a support for you because they know what it's like.
Dr. Katz, what makes a patient a good candidate for IVF versus other treatments?
Well, I mean, potentially every couple who wants to try IVF is potentially a candidate. Whether they're a good candidate or not depends on how you define that. So I think that it's rare that IVF is the first option for most couples. I think most of the time they'll benefit from doing some of the less aggressive treatments, even something as simple as ovulation induction or inseminations, or maybe even some diagnostic procedures. The ideal IVF candidate, a little history might be beneficial here. The first IVF baby was in 1978, so it hasn't been around that long. And originally IVF was kind of designed for younger women with tubal factor infertility. So it was a way to get the egg and sperm to meet outside the body. That's hence the name in vitro, in the lab, fertilization. In the 90s, a procedure called ICSI, where we were able to stick a sperm in the eggs, became perfected, and we were able to treat male factor infertility. And that was a huge change in the field. And then since then, we have used it for just about any cause of infertility, including unexplained. So now we use it for everybody. But you know, the best prognosis patients are going to be younger patients with tubal factor, because basically their eggs are good, the sperm is good, they just need a meeting place and that's what in vitro provides. So You know, if you start using it for women in their 40s with very low egg counts, then the success rate is poor. They still are a candidate to try because I feel it's very important for people to have that option, but they're not ideal candidates for it.
Dr. Till, you sort of already described the grading system of the embryos, but maybe if you could touch on what types of testing can be done on them to determine health, viability, things like that.
So there are diagnostic procedures, and then there are things that we can do in the lab to determine the health of the embryo. Typically what will happen is we will culture everything to the blast stage, which will be day 5, 6, or 7. And then from the cohort that make it, that's when we will either transfer, freeze, or do genetic testing. The field in general has moved away from day 3 transfers. So you're not going to see a lot of clinics that are still doing day 3 transfers. A majority of embryos will wean themselves out by day 5. So if you start off with 10 embryos, approximately 50% of those are not going to make it to day 5. So it's really a numbers game. You know, you go from 20 eggs down to 10 mature, down to 7 fertilized, down to 3 or 4 that will finally make it. So it's all about the numbers. When you reach the blastocyst stage, we can do something called pre-implantation genetic testing, which will test for the number of chromosomes in the embryo. You and me and everyone here have 46, XX for female, XY for the male. Embryos, about 50% of them will be abnormal. So they're abnormal for a whole host of reasons. Extra chromosome 3, they're short chromosome 2. It's all a completely random event. And that's what's thought to, these abnormalities are what cause miscarriage or failure to implant. So what we'll do is we will do genetic testing on these embryos and only put back the normal ones. So the ones that are 46XX or 46XY. And the success rate with those is incredibly high, as opposed to the ones that are abnormal that will not make a baby.
Okay. Let's see, let's move on to Robbie. What are some ways that husbands can support their wives going through the hormones, the shots, all the emotions?
Yeah, I think a little bit of just understanding. It's an emotional roller coaster for both of you, but especially for the female getting injected with the hormones and just going through the entire process of it is definitely a roller coaster. So I think being there, being a part of the process with the shots, you know, making sure that you're there, you're understanding what the injections are doing, asking questions of them, ask how they're feeling. In my wife's case, go get ice cream and cake when she asks me to, and be prepared for those runs when they want it. But just the understanding and being a part of the process, I think, is one of the most important things and the biggest thing that I try to do throughout our time together. And I do, just off of what Dr. Taylor was saying, I'm a big supporter of the genetic testing and having that done. I know it does cost a little bit extra money, but to me, it was well worth the money that for us that we did to get to that process.
Taylor, if you suspect you're facing infertility, what are some of the questions you should ask your primary care doctor or your OBGYN?
Yeah, that's a great question. So for most of our patients, actually seeing their OBGYN is their first step. On the female side, a really good question to ask them is, how does age impact my fertility? Because as women, we're born with all the eggs we're going to have, and so it's important to have realistic expectations and ask your OBGYN, what testing can I do to figure out my egg counts? And so I think that that's a good place to start. Some other things that you can ask are, you know, what should I do, you know, health habit-wise, so diet and exercise, or, you know, supplement recommendations, things that you can do that will help improve your outcomes. And then lastly, just what evaluation can we start with? So we get patients, you know, that are kind of along the spectrum of where they are in the evaluation. So you'd be able to start with a semen analysis at an outside facility, or like I said, get egg count testing. And so it's important to just ask those questions, and Samantha, you know, said this great, you know, make a list of all your questions so you make sure that everything's getting answered, because you will inevitably forget some of your questions if you don't write them down, and just make sure that you feel really good going into, you know, a fertility consult. Also important to know that you don't need a referral to come to REACH. So even if you don't have a primary care doctor or don't have an OBGYN, you can still make an appointment with one of our providers, and we can talk about your fertility journey.
Tyler, I know you talked about the SunTrust loan. Are there any other ways that couples could seek loans, subsidize care, find help to pay for treatments?
Yeah, so I first recommend going to your employer. A lot of employers will offer different healthcare insurance providers. For example, like my wife and I, we had the same insurance provider, but a friend of ours, they had a different insurance provider, and it actually covered part of their IVF cycle. So that I would start there first to see what your company provides insurance-wise. Again, if you're active military, the military, it's called TRICARE. They offer financial assistance for infertility. And then there's if you have equity in your home, another good option is what's called a home equity line of credit. Pretty much every bank offers this, but it's a tool that you can pull the equity out of your house, and then your payments are sometimes can be interest only, which are going to be your smallest payments, and then when you go sell your house, that would be added into the sale price and what you ultimately get back. So those are a couple options. Also, if you on the loan side, if you have a savings account, you're like, well, I don't really want to deplete all my savings account. Your bank can use the savings account just like a home equity line. They can use that as collateral and lend against the savings account, and you'll get a much more favorable rate, and you also keep your savings intact. So, my contact's in the information that you received. So if SunTrust can't help you, I can point you in a couple of different directions that may be able to assist.
And Kalisha, I know we've talked about support from your peers while you're going through this struggle, but I think it's also important that we acknowledge that it can be hard to watch other people have successes and to feel like everybody else's life is moving on in the direction that you hope yours would, but you're stuck.
Yeah.
What are your recommendations for folks facing those feelings and how to navigate that?
Yeah, so definitely for me, I'm a believer, so one thing I definitely lean on is that relationship with Christ, to just go to Him with those things. But then it's also important not to stop there, right? So don't stop with prayer and stop with just going upward in that way, but we need support from people that are here that we can see and we can touch. So I definitely believe in counselors, so making sure you do the research to find the right fit for you to be able to talk through some of these issues, because like we've said, Samantha has said, I've said, sometimes your family, they just don't understand, your friends don't understand, maybe if they haven't dealt with this infertility or miscarriages, they don't understand that some things that they present may be insensitive to you, or maybe, insensitive to what you're going through. So I think also doing the research to find the right people that you can talk to as far as counseling. And then I think just finding an outlet, whether that's going to the gym, whether that's going walking, whether that's finding yoga, whether that's getting a journal and writing your feelings out so that you can at least get those things out. Because if we keep them bottled in, then it can really be detrimental to us. So I think just finding the right outlet that works for you. And that takes research, that takes having some inside questions to yourself, and being sincere and being real with yourself at where you're at so that you know what outlets you need to look for.
Samantha, we know that you helped to found the Bundle of Joy Fund, and Robbie is up here to share his personal story. But for folks who may be beginning this and think that that might be something they'd like to pursue, a possible grant, can you explain the process and how the grant helps couples?
Sure. So we started the Bundle Joy Fund in 2015 after having Brexton. We're really excited. We'll be almost to the $1 million mark after this round of grants, so it's very exciting for us. And what we do is we provide grants. They're typically anywhere between $10,000 and $20,000 to couples that are patients at the REACH clinic. And so all you have to do is go talk to your nurse or doctor or the financial department, and they will give you a nice green folder. And inside you'll find the application, and it is a big application. And what's in it is we ask for your background and, if you've started treatment, and an application essay of tell us your story. And a lot goes into it, and we're really blessed to have Reach be able to, do the initial reviews on them, and then our team looks at them, and we grant 3 times a year. So we're very excited. To date, we have 37 babies born, and already 7 more on the way for this year. So we're very excited.
Dr. Katz, what are the pros and cons of fresh versus frozen embryo transfer?
All right. So it's also very individualized. So there are scenarios where a fresh transfer makes sense. If you test the embryos, it has to be a frozen transfer. So there's at least at most centers, there's not the ability to test the embryo and do a fresh transfer, because it takes about 10 days to 2 weeks to get the results back of the testing, and you can't just leave a little embryo sitting there in the dish for 2 weeks. So you either have to transfer it 5 or 6 days after the retrieval, or you have to freeze it. Now, most of the high quality centers have gone to predominantly frozen transfers for a couple of reasons. One, we noticed that when the estrogen levels were really high during the stimulations to get the eggs, that the success rates were lower. So the embryo isn't used to that supraphysiologic level of hormone when it gets into the uterus. So to normalize that, you do a frozen transfer, and the hormone levels are much more like a natural cycle. And so we noticed that the embryos did better. There was also some data out of Australia that showed that the complication rate associated with IVF pregnancies actually went down when you use frozen embryos versus fresh embryos. And I really don't know why that is. I think my theory is that it has to do with the hormone levels being so high at the start of the cycle, at the start of the pregnancy. But if a patient has the perfect estrogen level, the endometrium looks good, the embryos are developing normally, and they don't want to test the embryos, then a fresh transfer works perfectly fine. So I think overall our frozen transfer rates, pregnancy rates are higher than our fresh, but if you pick the right patient, then fresh embryo transfers work fine.
When it comes, Dr. Teal, when it comes to freezing embryos, what does that look like? How long can you freeze it? I think people probably have questions about what am I getting myself into with that if I am freezing embryos.
So everything within our lab, so we first have to start with the chain of custody, making sure they're your embryos. Everything within our lab, within most labs, I would say, everything is double and triple checked, even before. If I remove a dish from an incubator, there's somebody else there. That means on weekends and holidays, there's 2 of us there. So, there's always a double check. And then we double check the stickers, we double check the canes, we double check everything. So that's not the issue. When you freeze, it takes about 15 minutes per embryo. And essentially what you do is you put them on, it looks like it's called a straw, but it looks like a McDonald's straw, just a lot smaller. And you place the embryo on it, and then it goes directly into liquid nitrogen, which is negative 196 Celsius. So it's really, really cold. And the embryo can stay frozen indefinitely. So there have been case reports of embryos frozen 30 years ago that have resulted in babies. So the embryos are frozen indefinitely, and on that straw is your name, the date, every identifier. There's 2 or 3 identifiers that's been double or triple checked. And also, so then we'll put that in the freezer. The freezers at all of these clinics are not run on electricity. So even if the power goes out, nothing happens. What essentially it is it's a giant cooler. And if you actually left the top open with a lot of liquid nitrogen, if you actually let the top open, it's not going to evaporate for probably 2 to 3 weeks. So they're very, very safe. And then they also have alarms built in on the side of them. So if there's a crack, if the temperature drops, if the temperature fluctuates, we get a call, we get an email, and we get a text. And it's not just me, it's all the embryologists, all the androsteners, about 20 of us. And so those are monitored 24/7. Power outage doesn't matter. It all goes through the phone lines. So everything is monitored. When the power does go out, we'll get a text saying, hey, the power's out, and we have to go in there and make sure they're okay. So the way they're frozen is very safe, very secure, and everything is double or triple checked. And when we thaw it, we double and triple check again. So there are multiple avenues of checks to stop anything and everything, any mistakes. So that's essentially how they stay frozen.
And I guess my follow-up to that would be, is there any possibility that embryos don't survive the thaw?
Yeah, so nothing in this field is nothing in the world is 100%. If you look at the survival rate of embryos at the blast stage, you're about 98%, 95. I think we quote 95. So, but that's a little bit of a gray area because it's not all or none. So if you're dealing with 100 cells, maybe we look at it and go, okay, about half of the embryo survives. Do you call that survived or not? So we will typically end up transferring it. We'll talk to the patient and say, what do they want to do? And depending upon their clinical situation, we may transfer it. So about 95% of them survive. And yeah, that's pretty much it. I don't think I have anything else. Yeah. Sorry, I was going to go on to something else, but I completely forgot.
That's
So.
okay. There are a lot of levels and hormones and checks that are done. So I guess if someone is just beginning the infertility treatment process, I remember with my own experience, the constant blood work and ultrasounds and feeling like you were in and out of that office pretty regularly. If someone is just beginning that journey, can you explain, Taylor, why are those checks done so regularly and what exactly it is you're looking for?
Yeah, so it varies on what type of treatment you're doing. But you know, if you're doing a more aggressive treatment like IVF, you are there every couple of days. And on those days we are doing blood work and ultrasound. And basically what we're doing is we're monitoring your blood work, specifically for IVF, monitoring your estrogen levels to make sure that you're responding to the medications. The vaginal ultrasound is to actually look at the follicles, which is the fluid-filled sac that holds the egg. And we want that to be a certain size in order to produce a mature egg. So it does feel like you live at Reach for when you're doing treatment, and you know you'll see a lot of our providers. So we alternate days that we do ultrasounds. So it's really just monitoring your body's response to the medications and the treatment cycle to make sure that you're getting an optimal response.
Are there ever points, and I guess I would just open this up to any of the physicians from Reach, are there ever points in a treatment cycle where you would call it off? And if so, why?
Yeah, it happened today. A patient was about 6 days into her stimulation, and there was only one follicle growing, and she was using about probably $600-700 of drug a day, and I didn't think it was worth her continuing that process. So we stopped, and we'll see what happens without any medicine. But really, she'll probably have to start over again, the different protocol, and see if we can get a better outcome. So things like that happen. The response is not what you think, and so you think you can do better. So you'll stop the cycle and start over.
Samantha, what's your best advice for couples to remain hopeful? Because through this process, it's inevitable that there will be some sort of obstacle or disappointment or delay. So how do you navigate that?
You know, it's definitely hard. I think that, as we mentioned, the peer support is really important. I think finding a good church is really important. And then I really believe in couples therapy. This is a lot to manage. This is not ever something that when you said, I do, you thought you were going to have to face. Even for us, when we did face IVF, we were like, okay, you know, Braxton happened the first round. We were naive. We thought it was a guarantee every time. And now we're on our fifth cycle. And it's very draining. And so I think taking that time to focus on self-care and on your marriage, whether it's couples therapy or just doing activities that you're not always just focused on infertility. I know there's probably a lot of you out there that you feel like it runs your life and it's all that you talk about. And so really taking that time to say, okay, pause, we're going to have a date night. We're not going to talk about infertility. We're going to just do something that we enjoy. That's really important. And I think that helps you stay hopeful and stay grounded and really protect your own mental health and your marriage through all the stresses that you might be facing.
Thank you. I think we're probably ready to open it up to the floor and to our guests if anyone has any questions. Yes, sir.
This for any you've gone through it. So there's so much talk of the science side of stuff, and so like not coming to grips, but understand like it's not a natural process, and you just do everything in science. Did any of you have struggled with that, like with it being so much science and not, or no, or like it's just me? Or,
I think I don't know if you want me to weigh in, but
Oh,
I
you
think
might.
yeah. It is definitely an adjustment, as Samantha mentioned. This deals with a very intimate part of your marriage and your relationship, and all of a sudden you recognize you're talking openly with people about it, and recognizing that you need clinical intervention in order to grow your family is a difficult thing to accept. But I think the great thing that I felt at REACH was that they are compassionate and understanding and supportive, and it's not like going to the dentist. It's that patient care is at a different level, and I know that helped my husband and I when we were going through it.
Go ahead, Sam.
Oh, no, go ahead. I've been talking.
Yeah, I mean, just like you said, the people at REACH have been great for us and that support. And I guess, are you trying to get at the having to go through the science side of?
Taking this and that and doing this and that instead of just like
Having
just
sex and having a
yeah.
baby?
Yeah.
Yeah.
Must be nice.
Yeah, right? Yeah. Don't know what that's like.
But it's just just coming to grips with.
So I'm all into the science part of it. And this is the thing, like I am all obsessed with like the frozen stuff and the testing, and like I am like the Google queen, and I am like researching it now, hashtagging like everything, and I am all into the science, and I will talk about it all day long if you let me. But I have to kind of take a step back because it is kind of like, it is such a different process, and because it's not just having sex the old-fashioned way and the fun way, which, I'm one of over 100 grandchildren, so everyone in my family is clearly like Hurdle Myrtle running around. And so, but then there's me, and I'm the first one who we've not had, nobody in my family's ever had any problems.
Yeah.
And so, because it isn't very traditional, like my family can't seem to wrap their head around, well, my mom literally asked me, are you having sex enough? And I was like, I don't really think that's a problem. Like, so, it is like, it's hard, and like, because I do go into the science so much of it, I guess the real question is, how do you find the balance in between, like, it's still kind of like getting you to your baby, and it's not just like something that's happening in a petri dish kind of thing?
Yeah, I mean, quite honestly, my wife and I resigned ourselves to the fact that that's what we needed, and I never really thought about it the other way. At that standpoint, I just said, this is what we have to do. Learn as much, kind of like you're doing, learn as much as I can about the process, do whatever I can to be supportive in it, and not worry about the other stuff. If we get lucky enough and she winds up pregnant without this, great.
Yeah.
But right now I know this is what it looks like we're gonna have to do to be able to have a baby, then that's what I'm gonna do. And yes, I understand, people not understanding where you're coming from. When we first came out and said that we were struggling with it, my parents were like, why would you post about that? Because their thought was that's something that you keep private and you don't tell people about it. Through that, I've had so many friends reach out to me and say, we've struggled with infertility, we're currently struggling with it, or this is how many miscarriages we have before. Then you don't feel as alone as you felt before. So, and then you have that network like we're talking about of people that you can reach out to and say, tell me a little bit more about your process, because those people probably didn't have people they talked to. And so, yeah, I just resigned myself to the fact that this is what we're gonna have to do. Like I said, I'm the money person in our family, so I said, what do we need to do? Let's focus. I'll focus on that part of it, and I'll be here to be as supportive as I can through the process.
I do see what you're saying, though. It is, you feel like a loss of maybe you know, when you first start trying, you're excited to enter that new chapter in your life, and it's going to be so intimate in between you two. And then I literally joke around, like on the day we had our son, everybody else touched my vagina except my husband. Like everybody was in there. Teal, Ring, Mary, and then Kyle's just sitting there. And it takes away from that bond that you have with your partner. And it's hard. And so I think it's really important to refocus on your marriage and some of the things. Like, it's very natural to feel sad about getting to lose that ability to have that intimate thing and to do it like maybe other people are. But it's important to say, okay, you know, this is our option to have a child and that's what it's going to be, but let's focus on ways to love each other and find that intimacy in a different way. And so that's what we focused on doing.
Yeah. I don't think that it takes away from the value of your marriage
Right.
or your relationship in any way if this is the way you seek parenthood. Anybody else?
And it doesn't take away from the health of the baby. That's the bottom line. The science doesn't hurt the baby. And so, you know, keep that in mind. That
I was approaching it from, it's funny, I was taking it more of, this is more the practical person in me, but you know, you sit there, we talk about ICSI, where you're injecting a needle into an egg, or, you know, freezing. You know, we have things up our sleeves that we can do to minimize that sort of impact. Now, you'll be counseled as to, you know, what are the pros and cons of it. Like, so for example, we don't have to use ICSI to inseminate an egg. We can put the eggs with the sperm in a dish. It's a little bit more natural, but we certainly have patients that want to do that. We also have patients that want to freeze eggs as opposed to embryos because they don't want to generate any more life than they need to. So we can do that. So there's a lot of things that we can do to make it more comfortable. And we can certainly, one of the benefits of having such a large center in Reach is that we've worked all of that through before. You won't be the first one. And we know the data behind it, so we can say, okay, if you do this, you know, you won't impact anything, or if you do this, you know, you'll see about a 5% reduction. Are you okay with that? So that you guys can make an educated decision as to what you're comfortable with.
Anybody else have a question?
Yes, please don't be shy. Feel free to ask anybody up here anything. That's what we're here for.
Like you mentioned, you can freeze the eggs and the testes, so our situation's kind of different. Is there is the frozen less likely to be successful than the fresh? I guess for sperm or egg both. I'm just curious.
for sperm, generally no. For eggs, depends. Depends on the age and the quality of the eggs. I think frozen eggs are probably a little less successful than fresh eggs, but they still work well, and you know, maybe a 5 to 10% drop in overall success rates. So it's not terrible. So yeah, it just depends. But no, in general, you can freeze eggs and you can freeze sperm and get a baby.
What is considered old also?
No, I mean, so I'm old. So I'm 55. So if you walk in my office and you're 55, probably can't help you, okay? Anything under that seems young to me. So.
I will say, maybe that is an important question that we address, is that women in your mid to late 30s are often told you're advanced maternal age. What does that mean? And should a patient be discouraged by that title?
No, AMA it comes from the old data from the risk of an amniocentesis. Do you all know what that is? An amniocentesis is the way they used to tell if the baby had a chromosome issue, like Down syndrome or some other issue. They stick a needle in the belly when you're pregnant and suck out a little fluid, and then they can grow cells and tell. Well, the risk of a chromosomal issue at age 35 is 1 in 200. And the risk of the procedure, of losing the pregnancy from the procedure, is 1 in 250. So at 35, the risk of the chromosomal issue is higher than the risk of losing the pregnancy from the procedure. And that's where AMA came from. AMA now has, I mean, you know, AMA to me is a totally different thing than what you hear from your OBGYN, okay? So they still use 35. But for us, you know, there's a steady decline in fertility from your late 20s. So it's not like at 35 suddenly it falls off a cliff. In your early 40s, at 42, 43, yeah, it does start to drop pretty tremendously. But all the way up to 40, 41, that's young in my book, from an egg standpoint.
Can you speak on the process of insemination and the InvoCell process? InvoCell?
Okay, yeah, that's another tool. So, I mean, basically, it's like a little water bottle, and instead of in the lab,
This big.
yeah, thank you. But, sorry. Instead of in the lab where we fertilize and we'll observe them, what happens is you undergo the same medications, the same process. You know, we retrieve the eggs, and then basically we will put the eggs and the sperm together in the container, and we'll put that back into the vagina. And you are basically becoming the incubator. And so fertilization occurs inside you. The embryos grow within inside you, and then after 5 days, you come back, we take it out, and then we basically take out the embryos and we'll transfer them or freeze them or do whatever we need to do on them. That is another tool that's becoming quite popular. The problem with that is if you look across all the data across the whole country with that device, it seems to be lower than IVF in general. So that is the problem. It seems to be stuck in between where the success rate of IUIs and the success rate of IVF. So that's where that device will fall.
Can you explain why someone would, like, what would be the reason to choose that instead of IVF, and how common is it that people use that process?
You want to field that one? I mean,
So, I mean, it's cheaper.
Okay.
So that's the biggest reason people choose it, is it's cheaper than doing IVF by almost by half. So that's why. As far as who's, like, we haven't done a lot. There are centers in Texas that do lots and lots of these InvoCell. They have like InvoCell centers. You know, we do some. Most patients, when counseled about it, actually choose to do IVF, because in general you can't test the embryos with InvoCell. So you just put them back in and see what happens. And if the couple has never had fertilization before, where an egg has actually been fertilized by the sperm, then it's risky because you're just putting them together and you don't know that fertilization is going to happen. So we use it for same-sex couples because a lot of times they don't have a fertility issue. They just need sperm, and it's a way to do it cheaper than having to go through the whole IVF process. But you're still taking all the medicines you do for IVF, and you're still going through the retrieval process where you get the eggs out. That's all the same. What's different is you don't fertilize them in the lab and grow them in the lab. You let them fertilize on their own in this little capsule, and then see what you get.
so to give you an idea, you know, we talk about half the price, which sounds great, but you know, in the lab we can control it, we can see it, we can visualize everything. Typically, you're looking at a 50% blast rate. InvoCell, you might get one. So you know, it's not like a complete IVF cycle where you have multiple embryos and multiple times to go through again. It's typically an all or none type process.
Anybody else have a question? Yes, ma'am.
So you mentioned about trachea. What kind of outlets do people have to go through to get help with that?
Sorry, what was the?
The trachea, you mentioned how people can use that as an outlet for financial help.
Oh.
Yeah, how does that work?
The- Yeah, so I just actually, there was a good CNN article where Samantha was quoted here, was it yesterday?
Oh, what'd I say?
I'll give you the website. I've got it actually in here on my on this piece of paper. But I just, in that article where she was mentioned, it talked about different options. So I'll give it to you when we get done. Uh-huh.
So you have to go through your the VA, and they will send you to an outside center like ours.
Yeah.
But they only cover IVF, and I hope I'm not wrong, but this is what
It's like if he got injured.
if you
in
were
combat.
wounded in
Yeah.
battle,
Yeah.
and which
Which was
is
not
it's just the way our government thinks about things. Okay, so if you've been wounded, I mean, if you're healthy and you spent 8 years in Afghanistan, they won't pay for it. But if you had an injury, then they will cover it. God knows why that makes sense to them. I don't know, but you know,
They're
I
really confusing.
It
about
is.
What they will and what they won't. I mean, they won't pay for IVF or IUIs, but they'll 100% cover plastic surgery.
yeah. No.
So after, when you,
Def-
yeah.
Don't get me started on that, but,
Yeah, that's
you know,
frustrating.
I would love a federal mandate to cover infertility. I think it's ridiculous that we don't have one. Until there's 51 female senators, we're not gonna have one. But I do encourage you to talk to your HR departments, because the employers have the power, all right? It's not the insurance companies. They all cover IVF if the employer purchases that plan, all right? So it's all about the employer. So you gotta get, and I've heard stories, I've had patients tell me they went to the HR person and it wasn't that much to add it as an option. They just never thought about it. And so, you know, there's no reason not to ask and see whether they can add that as an option, because until there's a federal mandate, your best bet is to go to your employer and tell them that this is important to you.
And speaking of that, Progeny's website, if you go to there because you want to talk to your HR, they have a whole toolkit on approaching your HR department and questions to ask. Because you're right, most of the times it just hasn't been brought to their attention that this is something needed for their employees. And so they have great ways to kind of open up that conversation.
We've talked a lot about infertility from the female side of things, but maybe we should spend a little bit of time talking about male factor. And what kind of tests do you do on the men, and what could the potential issues be?
No.
Do you really want me to?
No, I mean, I've been talking though.
I can talk about it.
All right, Taylor, you take it over.
I'm just not, yeah.
So, I mean, the men, the evaluation's a lot more simple than on the female side. So basically, the initial workup is just to do a semen analysis. It's exactly what it sounds like. You collect a sample of sperm in a cup, you bring it into our office, and then we have people look at it under a microscope. So there's 3 kind of important things that we're looking for. Looking at the count, so the total count in the sperm sample. The motility, which is the percentage that are swimming, which are the ones that are going to be able to fertilize an egg, and then the shape of the sperm. And, you know, some of our patients will come to us with that already done, or we do them at reach. And there's, you know, a lot of different variations or abnormalities that there can be. We'll usually, if let's say the count's low, we'll initiate that evaluation. So it may include blood work to see if there's, you know, a hormone issue or you have low testosterone. And then if it's something that we think that would be better handled by a urologist, we'll refer you out to them just to get an evaluation so they can do a physical exam and dig a little bit deeper into the abnormality found on the semen analysis.
Here's another question from one of our audience members asking if you can speak on the process. Oh, no, we already did that one. If you aren't dealing with male factor, what are the benefits or are there any risks to doing ICSI?
So if you look at the literature, so ICSI's been around for 30 years. And if you look at the literature first starting to come out around the 2000s, there were some literature saying, you know, these children are a little bit developmentally delayed. And it turned out that research ICSI was only being utilized on patients with severe male factor. And it turned out that those patients, it was a subcategory of patients that were prone to that sort of developmental delay in children. So if you utilized ICSI in a regular patient population, there is no impact. So ICSI itself does not cause any harm to children or to the, or, you know, for them to reach their milestones. It's more geared towards the male side, how severe is the sperm, how severely impacted is the sperm. So the technique doesn't harm anything.
If you already know IVF is your option, but you need to go through medically induced menopause, how long after do you wait to start the IVF treatments?
I guess I would say, why are you going through medically induced menopause? If it's for cancer, then I would probably wait 3 months for the cycle to come back. If it's for like treatment of endometriosis, then I would actually try to get the eggs out first and then freeze embryos and then do the medical menopause before you put the embryos back in. And I would do that for 2 to 3 months of treatment. So it depends why you're doing that in the first place.
How do fibroids play a part in fertility?
It depends. Fibroids are like real estate. It's all about location. So, you know, you can have a giant fibroid that's at the top of the uterus. Fibroids are benign tumors of the uterus. They're extremely common. They're very common in African American women for some reason, and we don't know why, but they can get huge. And they're not cancerous, but they can distort the anatomy. So you can have a small fibroid on the inside of the cavity of the uterus, and that can create all sorts of problems with bleeding and cramping and affect the fertility process. And you can have a large fibroid on the top of the uterus, and it has no impact on the fertility process and doesn't cause any issues. So it really depends where the fibroids are. In general, if it's over 8 centimeters, which is 10 centimeters is a baby's head, so 8 centimeters is pretty big. If it's over that, you probably are going to need to do something about it. If it's under that, it really depends on where it is.
Does anyone else have a question? Yes, ma'am.
If you have gone through stimulation and then it was unsuccessful and you've been told you need to go to donor eggs, how does that play out and how are the success rates for donor eggs and timelines?
Yeah, I mean, donor eggs work great because you're taking presumably young, fertile women in their 20s and using their eggs. So those eggs tend to be pretty fertile and work well. It generally takes 2 or 3 months to match you with a donor, and then another 6 weeks to kind of go through the process. So it's about a 2 to 4 month process to go through. You know, from the recipient, so the person who's going to get the donor eggs, physically it's much easier to go through than stimulating on your own, because you're not worried about the ovaries, you're only worried about the uterus. But emotionally, it's, you know, you have to get there, right? You have to get to that point where you're okay with that. Once you are, then the process actually works very well. We see success rates certainly north of 60, 65%, even as high as 70%.
Yes, ma'am.
So I had a hysterectomy last year, but she has offered to be like a surrogate for me. So how would that process work? Like, does she have to basically go through IVF with like a sperm donation, or what exactly does that?
So do you want to use your eggs, or you had your eggs, they're gone?
They're gone.
Okay, so we don't actually do that. That's the one thing in the fertility world that we don't mess with, because it's fraught with all sorts of legal issues, and it's, you know, so yes, simple answer is you could do an insemination, but a lot of centers won't do that because we don't do true surrogacy where the woman who's carrying the pregnancy, it's also using her eggs. So we do a lot of gestational carriers where the egg comes from somewhere and the sperm comes from somewhere and a third party carries the pregnancy. because that person carrying the pregnancy has no biologic connection to the embryo. So in the eyes of the law, it's just easier and cleaner. When you have a true surrogate situation, there's nothing to stop that person from keeping that baby. I mean, there's nothing. There's no legal precedent anywhere that would help that situation. So that's why most centers stay away from that. I'm sure there's some up north that do it.
I'm not going that far. I'll adopt.
It's just, it's hard. It's the South, and even just using a gestational carrier can be a little tricky.
Oh, yeah.
So,
A lot of paperwork.
yeah, a lot of paperwork, and, you know, I mean, it's tricky.
Why would a urologist say that normal forms don't play a part in fertility, but REACH says they do? What is your opinion on that?
That's not true. That's.
I'm just reading the question.
Well, it's a setup question. It's not. So there is one urologist in Charlotte who believes that morphology has no impact on anything to do with anything. All right? And I actually lean towards his view of things. There was a giant meta-analysis, so a huge study that came out from the World Health Organization that showed when you look at morphology, at the shape of the sperm, 4% is what we call normal, but if you take it all the way down to 0%, they didn't see a difference in pregnancy rates, whether it was 4, 3, 2, 1, or 0. So, you know, I think it's an open question of how much morphology plays a role. And I generally don't use that as the primary reason for choosing a specific fertility treatment. But our literature says it affects fertilization. So when we do IVF, when we do IVF, if the morphology is poor, we will always do ICSI, because our literature suggests that poor morphology can affect the fertilization rate.
Yes, sir.
What's like the average cost of like going through the first round? Is
15, 16 grand with the meds, something like that.
Yes, ma'am.
You kind of teed it up. As far as like doing your first round of IVF, Taylor's my doctor, so like it's kind of the next step here. But I know some companies, when you do it, like if it doesn't work, outside of being a hopeful thinker, like will it include another transfer, or is it like you're done, you can do another transfer, and you start from scratch? Which I know it can depend on the person, but kind of what does that first one look like as far as including?
Yeah, so if you go through an IVF stimulation and you get multiple embryos, then you'll have the remaining ones to transfer at a later point. So then you would just pay for the transfer aspect of it, and that's much cheaper than going through the stimulation part. So if you only had one embryo, then you may need to do another stimulation. So it just depends on what your success from the first stimulation is to determine, you know, what the cost in the future would be.
Okay, so if you had to do a transfer after that, it would just be like you pay kind of whatever the fee would be.
A couple grand.
I think,
or so.
I'm sorry.
Yeah, go ahead.
Yeah.
I think ours was around $4,000, something like
Mm.
that, when we did our second transfer.
Okay, that makes sense. Thank you.
And we do have some programs that like bundle stuff, so you pay one price and you get multiple tries, and then the frozen transfers are kind of thrown in with that. And then if you don't get a baby, you get a partial refund.
I've heard of that, I just wasn't sure how, like, kind of REACH had it structured.
Yeah, we have one of those. You
Okay.
have to talk to our financial
Oh, yeah,
counselor.
that's fine.
She'll go into that.
If your eggs are healthy quality, what is the percentage of insemination working?
IUI versus IVF, is that?
It doesn't specify, but
Yes.
yes.
Yes. So first off, there's really no way to know the eggs are healthy. All the testing we do is about ovarian reserve. It's about egg quantity. There really isn't a test that tells you whether the eggs are any good or not. So we generally assume, I hate going back to age again, but we generally assume that egg quality tracks with age. So as you get older, egg quality goes down. So let's say you're 29 and you're doing an insemination, the success rates are about 20% per try.
Yes, ma'am.
If your first transfer fails, what's the waiting period if you need to, like, when you're ready to do the second one?
You can roll right into it.
Oh, okay, cool. I didn't know if it was like 6 months or.
No.
Uh-oh.
For the stimulation of the ovaries, I always like to at least take a month off in
Okay,
between.
but if it's just for the transfer, it's.
You can roll right into another transfer. Because you're just thickening the lining,
Uh-huh.
and then so, once it doesn't work, you have a period and you're back to baseline and you can start up again.
Thank you all for your questions and for being engaged in our summit. Oh, do we have one more question?
I have a follow-up question to my friend in the back question about IUIs. So we had 3 IUIs, they all failed, one was a miscarriage, so I took care of it. At what point would you say it would be better for us to do IVF instead of the IUIs? And if we have a limited number of frozen sperm, what would that, should we just move on? Kind of question. Because you said IVF's not guaranteed either, but it seems like the rates are higher. What,
Yeah, I mean, your rates are, depending on your age, 60% for a transfer of a single embryo versus, at best, a 1 in 5 shot for an IUI. So, I mean, you only need 1 vial to try IVF. So I would make sure I saved at least 1 vial, maybe 2. And, the data shows that 80% of the pregnancies with IUI happen in the first 4 tries. So I think, it's diminishing returns if you go 5, 6, 7 IUIs.
Thank you, everyone, for all your questions. We wanted to remind you that if you open up your folder, there are raffle tickets inside, and we have 7 different raffle prizes that we would like to give out. And Samantha, do you want to kind of help me do
Sure. Oh, what's to sleep? I think.
I'm
Hold on.
donating mine.
I'll let you pull the
Yes,
number.
I'm not taking a prize.
So the first one is a gift certificate from Dr. Michelle Bilstein, which is Samantha's acupuncturist.
She's a fertility acupuncturist, and she's amazing. And that will go to ticket number 129033.
Oh, there we go.
Congratulations. That's wonderful. The second is an essential IVF kit from My Vitro.
That will go to 128826.
Congratulations.
That's right.
The next one is a gift certificate from Karen Rich, fertility coach.
That will go to 129003.
Congratulations.
I'm real sorry this side of the room.
Yeah, this side's racking up.
The next is a gift box of fertility support from Pre-Mama for him.
That goes to 128842. This side of the room.
The next is a gift box of fertility support for her from Pre-Mama.
That goes to 129006.
Congratulations. Yeah, it is this side of the room. And
Just move to this
a
side.
gift box from Theralogic.
Goes to 129030.
Man, oh my goodness.
That's crazy.
And lastly, another gift box from Theralogics.
Come on, left side.
All right. 129055.
Thank you.
It's like roulette. It's got to hit sometime.
So we are so grateful that you could all be here with us in person and virtually. We hope we answered your questions and provided you with some hope. And I know we certainly wish you the best of luck in your journey. I hope that you can all join us now as we go to Fahrenheit for a sunset toast and watch the skyline turn orange.
Thank you everyone for
Thank you.
coming. We really, really
Thank
appreciate it and hope you learned a lot. If you have any follow-up questions, you can always contact us on social media or head to Reach and they will get you a consult and go through everything. So thank you to the panel, to our amazing sponsors, and for everybody coming. Thank you.
Thank you.